Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is Accommodate or Correct, a comparison of what you are trying to accomplish when the postural abnormality is reducible versus non-reducible. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary, depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Ana Endsjo. Ana is an occupational therapist with a Master's of Occupational Therapy degree from Nova Southeastern University and a Bachelor of Nutrition and Dietetics degree from the University of Delaware. Ana has worked as an occupational therapist for over 15 years, mainly with the geriatric population in a variety of treatment settings, including acute care, subacute care, outpatient, acute rehab, long-term care, and as a lymphedema certified therapist. Over the last 9 years, she's been dedicated to the betterment of the treatment of elderly in LTC centers. Her time was focused on seating and positioning and contracture management of the nursing home residents. Through this experience, her hope is to guide other therapists, rehab directors, nurses, and administrators through blogs, webinars, and live courses to be able to do the same. And now, please welcome Ana.
Thank you so much, Robin. And as she mentioned, my name is Ana Endsjo, and I will be the presenter for today's course. And today's objectives are that, number one, I would like for you to be able to define a reducible versus non-reducible postural abnormality. Number two, identify when to accommodate for and when to correct the postural abnormality. And then number three, name one method to accommodate for a postural abnormality when a posterior pelvic tilt is non-reducible. And by the end of this course, don't worry, all of this will make a little bit more sense. So the first thing that I wanted to do and discuss today is really just think about the importance of taking continuing education courses in seating and positioning, which is exactly what you all are doing. So by doing this, it really kind of helps us to keep up with the times, understand new procedures, think about new products on the market that maybe weren't there 20 years ago, and definitely learn about any changes in terminology. And this is one of those teachable moments. So the gurus in the seating and positioning world are trying really hard to make uniform terminology and really clean up some old concepts so that therapists everywhere are on the same page. So the terms fixed and flexible, which is what I learned, are now have changed to reducible and non-reducible. So the question going through your mind probably is, well, why the upgrade? And the answer is really simple. When we talk about something being fixed, it really implies stuck. And that means that it's not going to get any better, but it also implies that it's not going to get any worse. However, we know that that's just not the case when we're discussing these postural abnormalities. If we do nothing and we have no intervention with the proper support system, then the postural abnormality will progress and get worse, no matter if it is reducible or non-reducible. So what questions should we ask ourselves to determine if the postural abnormality that we're seeing is reducible or non-reducible? And the first and most obvious question is, can the client move in and out of that abnormal posture? But take it one step further and think to yourself, if they can move out of the posture, can they tolerate sitting with a neutral pelvis and spine? And this is a very important question to ask to determine whether the goal of the equipment is to correct or accommodate for the posture that we're seeing. So if you answered yes to both of those questions, then you come up with the fact that your postural abnormality is reducible, which means that the client can safely move out of that posture to a more neutral midline position, and they can tolerate that change for long periods of time without causing undue pain or stress on the body. When a reducible posture is present, then the goal of the equipment that you're going to be choosing is to correct the posture. Moving on, if you answered no to either of those questions, then the abnormal posture is non-reducible, since the client cannot move out of it. And also, if they can move out of it, then they're not capable of tolerating that for long periods of time. And so this changes the goal of our equipment completely to accommodating for the abnormality. It is during the evaluation process that we really decide whether the postural abnormality we are seeing is reducible versus non-reducible. And there are important steps in the evaluation process to ensure that we're asking the right questions. Then take the time to observe the client in the current wheelchair system, and also to then get them out of the wheelchair and perform the MAT evaluation. And that's going to lead us to what are the interventions that we should be taking. And the first three steps are, number one, interview the client, the family, and the caregiver. Step two, observe that client in their current wheelchair system to see what issues might be causing the postural abnormality. And step three, perform the MAT evaluation. And it's really critical that we get the client out of the chair, place them on a firm, flat surface, and really look at what the body is doing to decide if that postural abnormality that we're seeing is reducible or non-reducible. And then steps 4 through 7 that you see up there on the screen are really the intervention steps. And it's important that once we've identified the issues at hand, that we then take appropriate measurements, decide on what equipment we need to trial, because we always need to trial, then listen to the client's feedback and see what the reaction their body is having to that equipment that we're trialing to see if that is the most intervention before we make a purchase. Because something on paper might look great, but it might take us 3 or 4 different trials to actually get what's appropriate for that patient. And then after that equipment arrives, it's imperative to educate the client, the family and caregivers, and any staff on that new wheelchair system, the configuration, and then the care of any of its components to make sure that they're carrying over so that the client looks exactly how we originally had placed them in that system. So during the interview process, we need to ask the client, the family, and the caregivers very specific questions in order to learn what their goals are. It doesn't matter what we want for the patient, it really matters what they want out of their wheelchair system. So what do the client and the family want out of this new wheelchair system? Ask both open-ended and closed-ended questions to really start that investigation. And some questions would be things like, what functional activities do they want or do they need to be able to perform? Do they have a pressure injury right now, or have they had one in the past? And I really want to pause right here and talk about this question for a second, because this can be a really, really sensitive issue for some families. So families, when you ask this, they might feel that if they answer honestly and say yes, they've had a pressure injury in the past, or they actually have one right now, they may feel that it's going to be perceived that they're not taking good care of their loved one. Or maybe they're going to think that you're thinking that they're unable to independently care for themselves. And it's not that anyone wants to lie to you, but out of fear, they just may omit very critical information. So we need to help them understand that we're not asking this question with judgment, but simply so that we can prescribe the best intervention possible to help heal the wound or to minimize the risk of a re-injury. So again, ask the question, document what the family says, but then take a good hard look at the skin later on during your hands-on evaluation. So the next question is, do they have pain in the current wheelchair system? And if so, where is that pain? Is it along the spine's process? Is it underneath the ischial tuberosities? And this is really going to point you in the direction of hot spots that are areas that are a high risk for a pressure injury. Especially, it's going to point you into the area of where there might be the development of a deep tissue injury, where usually the only sign is pain. And then if the client cannot verbally tell you what their pain level is, if you're having a patient with dementia or literally they just are nonverbal, then ask the family and caregiver questions that really expose those telltale signs that would indicate that someone's in pain. So ask them if the client presents with an increase in agitation when they put them in their wheelchair system. Or when they put them in, do they start excessively fidget or move around? Do they scream out constantly? Do they say things like, help me, or are they reaching out excessively to you as you're walking by? Because these are classic signs that indicate to us that someone that is nonverbal or is having some type of cognitive impairment is in pain or discomfort. As well, ask them what equipment they have used in the past. Maybe you're going to discover that they only use the transport chair that they're coming into you with, and that they've never put a cushion between that client and the seat sling. And then lastly, ask about medical issues. Has the client had any recent injuries or any medical decline that might actually affect what you're really seeing in this present moment? Maybe their baseline is drastically different than what you're seeing. A classic example of this is, think about a patient that's just had a urinary tract infection or is just getting over a bout of pneumonia. They're going to be weaker. They're going to be a little bit more disoriented than their normal baseline. And if you give them 2 or 3 weeks to actually completely recuperate from that illness, then they might present completely differently. They might not need as much support. So you just need to make sure that what you're seeing at the time of evaluation is their baseline. So what I'm going to do now is I'm going to use this resident, and we're going to name her Mrs. C, and I'm going to use her throughout the course to really walk you through steps 1 through 3 when I performed her evaluation. So with her input and the input from her husband, we were able to make amazing changes to her wheelchair system and really improved her quality of life and allowed her to function again in society. So as I said, I'm going to take you through the evaluation process with her, focusing on steps 1 through 3 that led me to the interventions that allowed me to improve her quality of life. And the first step, like I said, in that interview process is asking the right questions. And I asked both Mrs. C and her husband, and through that interview process, I found the following goals, right? And the first one is that Mrs. C wanted to see her husband better when she was talking to him. And if you look at her head in this picture, she's really an excessive forward flexion with a little bit of rotation. And she was unable to even raise her head up against gravity to talk to him. And she actually reported to me that she missed looking at him and she missed that intimate eye-to-eye contact. And I can tell you, I'm a little softy, and that really pulled at my heartstrings for sure. And then her husband had a goal, and he said that he wanted to be able to get her out of bed for longer periods of time without her fatiguing so that he could take her outside, because evidently they enjoyed tremendously walks out in nature. He also wanted to get her out so she could start being an active part of bingo and the church activities they had going on. And currently, at the time of this evaluation, she could only last about 45 minutes in her wheelchair system, and then she would get so wiped out that she needed to be put back to bed, and usually for the rest of the day. Both the client and her husband wanted a posture that really promoted better voice projection so that she could have conversations with the people around her. And he could barely hear her when she spoke. And because she said it required so much strength for her to engage in a conversation with her husband, or even just to make one little simple need met to the CNAs or the nurses around her, that she would then quickly fatigue without the energy to then project her voice. So the family and the staff were actually reporting to me that they would have to put their ear on her mouth to even hear the faintest whisper that she was able to produce. And also, Mrs. C complained of 8 to 10 out of 10 pain while she was sitting up. And she really said that this pain would come in her neck and her shoulder, at her trunk, along her spinous process, and then on her pelvis, along her sacrum, and at her ITs. And she wanted that pain to go back down to 0 out of 10. And then, due to the dependent position of her arm, she had edema in that left hand because she had a massive stroke and she couldn't move that arm. And her exact words was, she felt ugly to passersby, and she wanted less swelling in that left upper extremity. And then the family, the both of them together, were just very clearly could see that the current wheelchair system that you're seeing in this picture just could not provide her the stability and the alignment for her to achieve the goals, and they just wanted something better. So step 2 of the evaluation process is to observe the client in the wheelchair that they come into you with. And that's something that we as therapists are great at, right? We've been trained to observe, and we have these wonderful observational skills. And as a rule, I live off of the early, during the early stages of any evaluation. I think to myself, don't talk, just watch. Observe the client in the seated posture, in the wheelchair system that they're currently in, and then make a problem list. See how the posture in that system is impacting function. And I always start at the top, and I kind of work my way down. So look at what the head and the neck are doing, and how are they being affected by gravity? Is their eye gaze downward, upward? Are they constantly looking to the left or to the right? Can they even interact with the environment and the people around them? Then I'll look at the upper body. Are the shoulders really rounded in an excessive kyphosis, and how does that affect their upper extremity range of motion? Does whatever postural abnormality they have affect their ability to reach out of their base of support, reach the sink, to turn on the water, or brush their teeth, or perform their grooming tasks, or reach up into the closet to get their clothes? And, are their ADLs being affected by their trunk posture from the wheelchair level? And then I'll observe the pelvis. Are they sacral sitting? Or is it that they're more leaning into an obliquity? Or are they rotated in the chair? And how is this placing them at a high risk to fall or to sustain a pressure injury? So after observing Mrs. C in her baseline wheelchair, I was able to unfortunately make a very long problem list that I'm going to go through with you right now. And the first thing that I noted was that the wheelchair was simply just too wide and too short. So you can clearly see from the pictures that are marked with the number 1 that as a result, her pelvis is sitting halfway up the seat sling with the majority of her femur, and you can see this right here, not even making contact with the seat surface. And it's because that chair was so short and so wide, and her pelvis just then collapsed into a posterior pelvic tilt. The second issue has to do with the back support. And I always talk in my courses about the importance of measuring for the appropriate width, height, and especially the appropriate height of a back support when you're trying to achieve optimal stability. And the measurement should be that you should get them on the mat table and measure from the top of the mat table to the top of the shoulder. Yet this back support, and you can see that right here in this picture, is a good 6 inches above her shoulder. So this tall, very taut back support is pushing her forward, demanding that she start using her own core strength to sit up against gravity. But the problem is she's had 2 massive strokes, she has very poor trunk strength, and she cannot maintain that pressure against gravity, and so she just collapses when she fatigues at the chest and the abdominal cavity due to the excessive kyphosis that you're seeing. So the third problem that we had with that back support is that it's also too straight, really lacking the ability to conform to her spinal curvature. And whether it's her who has a very significant kyphosis or you and I that probably have a more neutral, normal-looking spinal curvature, we're not flat. So these straight back supports that don't support our natural curvature or an abnormal curvature really only make contact at wherever the apex of that curvature is. So when you're dealing with someone like her who has a significant kyphosis, then that apex of the curvature is going to be digging into the back support, really creating a peak pressure at, making her at risk for skin breakdown. And she did. She had reddened skin and she was very painful at where the apex of her kyphotic curvature was along the spinous process. And then number 4 on the problem list is that as a result of that chest and that abdominal cavity collapsing into that kyphotic posture, her lungs were really compressed, and then she was having a hard time breathing. So to compensate, what she would do is she would take shorter, more rapid breaths instead of deep, adequate breaths. And this breathing pattern actually causes you to expend a lot more energy, and she would fatigue even faster. So then it became cyclic. She would fatigue because of how she was breathing. She'd collapse. Her breathing would be compromised. She'd breathe more, harder. She'd get exhausted. She'd collapse even further. And like I said, the pattern kept repeating itself. And the poor respiration also started to affect her ability to, again, project her voice and communicate with the people around her. And then the 5th issue is that the kyphotic posture also pulled her head and her neck into that forward flexion and the rotation that you're seeing. And so the muscles had tightened, really preventing her to be able to bring her head up against gravity. So she was stuck looking down at the ground all day long and missed, again, like I said, that intimate contact with her husband and the people around her. Then, unfortunately, the list goes on. And, the treating therapist that I came in to help out really attempted to correct her lateral lean by placing this oversized foam lateral in her chair. And I think this was done for a couple of reasons. Number 1, I think what she was trying to do was make up some of the space since the wheelchair was too wide. And then number 2, because the back support being used was made up of a soft upholstery, there was no hardware on it, she wasn't able to actually mount a lateral that could then, give her counter pressure in an exact spot to bring her body up to a more upright midline posture. So this oversized foam support, which is the 6th issue, really promoted the client to lean into it. So since the back support couldn't give her the stability that she wanted, and she was so desperately trying to seek, that large surface area of the foam lateral gave her a very safe place to lean into and promoted her issues even more. So the next issue, the seventh issue, is the use of elevating leg rest. And in courses that I have taught in the past, I talk about the fact that elevating leg rests are really overused, especially in the nursing home setting. And a lot of times they can do more harm than good. And unfortunately, I can't get into all the reasons right now. But one thing I do want you to understand is that the higher and higher you elevate a leg rest, it's going to pull on your hamstring muscles. And when you're seated in a wheelchair all day long, your hamstring muscles shorten. And so what happens, like I said, the higher you go with that elevating leg rest, it starts to pull on the hamstring muscle that is attached to the ischial tuberosities at the pelvis. So it begins to pull that pelvis into a posterior pelvic tilt, which is also known as sacral sitting, and it's pulling the client straight out of the chair. And when it pulls the pelvis into that posterior pelvic tilt, it puts pressure right on the ITs and the sacrum. So this not only increases their risk for skin breakdown right at those areas, but it also increased her pain. And as I said, she was experiencing 8 to 10 out of pain in that area. Another problem with the elevating leg rest is that they do not allow for the thighs and the lower extremities to really make contact with the seat support surface. So when that happens, then gravity will take effect and really, either cause legs to fall together or maybe fall off the sides or maybe even sweep into a windswept deformity. And in her case, she was internally rotating at her hips, she was adducting at her legs, and her knees started to rub together. And then the last issue had to do with that hemi-tray. And this model of wheelchair that she was placed in lacked a ton of adjustability, but one of the things that it lacked was armrest height adjustability. So it was set very high for her. And then when they put the hemi-tray on top of the padding on the armrest, it just made it that much higher. And that excessive height really just pushed her over into the opposite direction. And then it also put a lot of stress and strain at her neck and her shoulder joint, which again is where she complained of pain. And the fact that hemi-tray couldn't be elevated, it did nothing to tackle that edema in her left hand. Okay. So now that we've interviewed the client and the family to understand, what are their personalized goals, we have to observe the client in the wheelchair, and we've made the problem list. Now it's time to kind of roll up our sleeves, get them out of the chair, and perform the mat evaluations. And no wheelchair evaluation should ever, I'm going to repeat, should ever be performed from the wheelchair itself. We must get the client out of the wheelchair, place them on a firm, flat surface to perform both the seated and the supine evaluations. And this way, we're going to be able to get a true picture of what their range of motion limitations are, and then we'll be able to test if that postural abnormality that we observed in the chair is reducible or non-reducible. So when performing both the seated and supine mat evaluations, we need to palpate the bony landmarks of the ASIS, which is your anterior superior iliac spine, and your PSIS, which is your posterior superior iliac spine, and that's going to help you to identify what is the pelvic abnormality that I'm seeing. Then you're going to take the client through passive range of motion at all the joints to identify range of motion limitations and to answer the question, is this reducible or non-reducible? The next thing you're going to do is then get out your goniometer and take some measurements to really help translate the range of motion limitations that you're seeing in the seated posture of the mat to the wheelchair. So we'll be able to adjust angles. And for example, if I'm taking, we're going to use this picture right here. And if I'm taking a range of motion measurement of this client, and I found that she is stuck at 75 degrees of extension, which is what she's sitting in right now. Okay, and I have found that this is non-reducible. I can't bring her closer to 90 degrees. She is stuck at 75 degrees of extension. Then that translates to me having to open the seat to back angle of my wheelchair to 105 degrees to accommodate for that lack of range of motion at her hips. Okay, if I keep her at a 90-degree angle, which this chair is stuck at, then she's never going to be able to bring her hips all the way back because her body can't even make that angle. So what's going to happen is exactly what you're seeing. You're going to see half of her, her legs completely falling off. You're going to see gaps being made, and her posture is just going to progress and get worse. She's going to start sliding out of the chair. She's going to start putting more pressure right under those bony prominences and cause a whole slew of issues. And then the last thing I have for you is a question. And my question is, do we stretch the client before we perform this mat evaluation? And the answer to that question is no. So I know that as therapists, it's our nature. We want to fix everything. We hope to return everything back to quote unquote normal, right? However, when it comes to seating and positioning, we've got to understand that these clients spend most or all of their day in that wheelchair. And we can attempt to change muscle lengths, but once they're off caseload, will that actually be maintained? So all the stretching, all the lengthening of the muscles, all the range of motion that we've gained when they're on the mat table is probably not what is realistic inside their wheelchair system. We want realistic measurements of the client and what they will present with inside of their wheelchair, and that is what we should be trying to correct or accommodate. So keeping with that realistic theme, perform the seated assessment, to define the optimal posture that can be realistically achieved against gravity. So with the seated evaluation, you really want to identify how much stability at the trunk and the pelvis is needed. And then you can start using your hands and your body and pillows and cushions to see what, to simulate what can they tolerate and what you will be able to achieve in the wheelchair with the equipment. So now what I'm going to do is I'm going to place a video that's going to act as a lab for you guys to really show an example of a very good seated mat evaluation.
When you've identified an abnormal posture, the next thing you really need to think about is whether that posture is fixed or flexible, or rather reducible or non-reducible, okay? So that means, can it change out of that position, or has their musculature, their tendons, have they shortened and that position has become their new normal? So this is what we need to look at, and there are different ways of identifying. Let's start with the easiest way. I have my patient here seated on the mat table, and I'm just going to ask her, can you straighten yourself out? Okay, so in this case, she can straighten herself out, and obviously she's a high-functioning person. Okay, if you don't have a high-functioning person, then they're in their posterior pelvic tilt. What I would try to do is I would manually try to shift her pelvis. And so I'm going to reach around to her PSIS as close as I can, and I'm going to try and bring her into a more neutral pelvic position by supporting her PSIS. And now I can see that she can come out of that posterior pelvic tilt. We could correct it with the proper equipment. The next thing is if you try and correct it, and she doesn't move. Okay, now I'm thinking, well, this may not be a reducible posture. And so my next step from there would be to lay her down on the mat table in supine.
Okay, so Stacy led us right into the next slide, which is the supine assessment. And again, you've got to get them out of the wheelchair. You've got to get them on a firm, flat surface. Take them through passive range of motion. But this time it's going to be in a gravity-eliminated plane. That way, you're going to be able to truly see how much movement they have at each joint to answer that question, is it reducible or non-reducible? And what I've done for you guys is I've kind of come up with some, let's say, cheat sheets. And as you're performing the mat evaluation, these charts are there to help guide you as to what is it that I might be seeing and what does this actually tell me. So, for example, when we're performing the supine mat evaluation and we're focusing on the knee, okay, if the left and the right knee cannot be flattened out to really have, that popliteal fossa make contact with the mat table, then this is cueing me in that I'm looking at someone who has a flexion contracture of the knee and it's non-reducible. Okay? Another tip is that when you're passively trying to straighten the knee out, if that pelvis also pulls toward you and lifts up off the mat table, then this is an indication that you're dealing with very tightened hamstrings, because that hip and that knee and that pelvis are all working as one unit. And, those tightened hamstrings are pulling the ITs of the pelvis, that you will probably then have to accommodate for that by opening the seat to back angle in the chair. And then lastly, if the left or the right knee stays flat against the mat table and you cannot passively flex it into flexion, then you're probably dealing with a non-reducible knee extension contracture. And again, we'll have to accommodate for that in your wheelchair system. If I move on to the pelvis and I'm testing to see if what I'm looking at is reducible versus non-reducible, if the client's legs, again, can't lie flat on the mat when you're trying to passively bring the hips and knees into full extension, then this triggers us to know that we're dealing with a non-reducible hip and knee flexion contracture. If with passive range of motion, the client's pelvis, trunk, and lower extremities are moving as one unit, and we're not able to really disassociate movement of one area, from the other area, then the postural abnormality, whether it be the posterior pelvic tilt or an obliquity or rotation, etc., are non-reducible because the body cannot move in separate parts. If you're dealing with a windswept posture, which is that look that the legs are being swept off to one side of the wheelchair, and when you're trying to bring the lower extremities back to midline and the entire pelvis begins to rotate with the legs, then it's a sign that it's a non-reducible windswept deformity. And so with passive range of motion into hip flexion, let's say, a normal reaction would be that as you raise the leg into hip flexion, the pelvis should stay flat on the mat. If, however, when you go into the passive range of motion of hip flexion, and the pelvis also raises up and kind of curls up with it off the mat table, and you're unable to disassociate, again, the movement of the hip and the pelvis, then you know for sure you're dealing with a non-reducible posterior pelvic tilt. And if you're trying to range those, into hip adduction, or you're trying to take them into abduction, and the pelvis again begins to roll as you're trying to take the lower extremities through that movement, then again, this is an indication that you're dealing with a non-reducible pelvic obliquity or rotation. And then lastly, if the left and the right side of the pelvis cannot touch the mat table at the same time, so let's say you're trying to lay the patient flat, and one side of the pelvis is digging in to the mat table, and the other one is barely making contact and is more up in the air, like kind of closer towards you, and you're unable to bring it down to make both of them even and flat, then you're definitely dealing with a non-reducible pelvic rotation. Continue moving on up the body, and if we're taking the trunk through passive range of motion, and if once you've laid that person down on the mat table, their lateral flexion isn't able to come back to midline. So the way I kind of always describe it is they kind of look like a candy cane. They're very curved at the trunk, and they're leaning to the left or to the right, but their legs are still straight in midline. If you're unable to bring that trunk to now be straight in midline with the lower extremities, then you're dealing with a non-reducible scoliosis, which is what would be causing that lateral lean. If when you lay them down, the shoulders cannot lie flat against the mat table, and the client stays with rounded shoulders, so like their shoulders are coming up towards you, and they're in that very kyphotic posture, and the head cannot even touch the mat table, then you're definitely dealing with a non-reducible kyphosis. If you move down the back, and if in the lower area where the lumbar area is, you can't get that lumbar area to lay flat against the mat table, and there's a gap where you can easily place your hand between their lumbar region and the mat table, then you're dealing with a non-reducible lumbar lordosis. And the same idea with the pelvic rotation. If you try to lay them flat and one of the shoulder blades is really digging into the mat table and the other one is lifted off the mat table, more elevated towards you, and you're unable to turn it to, for both of them to touch equally, then again, you're dealing with a non-reducible spinal rotation. And the truth of the matter is, the key here is if we cannot decompartmentalize the pelvis and the trunk and the lower extremities one from the other, and we're moving as one large unit, it's a dead giveaway that the pelvic and the trunk postural abnormalities are non-reducible. So assessing the head and the neck. And with the head and the neck, if the head cannot touch the mat table, and we've seen this, you lie someone down in bed or you put them on a mat table and their head stays up, and you have to pile 4 or 5 pillows underneath of them just to take the stress and strain off of their neck, then you're definitely dealing with a non-reducible forward neck flexion. And if while lying in supine, the head cannot be brought back to neutral so that they're, head straight and they're looking straight up at the ceiling when they're lying supine, but instead what's happening is that they're putting constant pressure on their left ear or constant pressure on their right ear, then you're dealing with a non-reducible neck rotation. And then if, again, you cannot bring the head back into a neutral midline and they are excessively looking to the left or to the right, then you're dealing with a non-reducible lateral flexion. So here's Stacy again to show us a good supine mat evaluation.
This supine position is really important when assessing abnormal postures and whether they're reducible or non-reducible or fixed or flexible. Okay? Now, if you think about Jamie, when she was sitting at the side of the mat table, she was sitting in a posterior pelvic tilt with her shoulders rounded and a kyphotic spine. So now I've put her on the mat table, and if you don't have a mat table, you can use the bed. If you're in someone's home, you can get them on a sofa if needed, but just as firm of a surface as possible is going to get you the most realistic and effective result. So now take a look at Jamie, and she is completely flat. So that tells me that her spine is flexible. It's not stuck in this position. Her neck is not stuck in this position. And obviously her pelvis is flexible because look at how her legs are lying flat. Now, if her posture would have been non-reducible or more fixed, her head would have been like this. We would have had to provide more pillows to support that posture. Her legs, on the other hand, would have been more bent, okay, so we wouldn't have seen this flat posture. If I laid her down and this is what I saw, and you can rest your head, Jamie, what I would do next to really see what's happening at the pelvis is that I would palpate and find the ASIS, and then I would flex the knee and flex the hip. And I'm feeling, as I'm doing this, I'm feeling to see whether the pelvis is just tolerating that and not moving. That means there's good mobility there. But if there's not good mobility, what I'm going to feel is the pelvis is going to start drawing forward as I bend the knee up. That's going to indicate that she has shortened hamstrings and she's going to move as a unit. And you would actually see that motion. So again, you want to flex the knee and then bring the hip into flexion like this while you're feeling the ASIS. So you'll notice that I use the terms fixed or flexible, and I used reducible or non-reducible. The terms really have been changed to reducible and non-reducible because whenever you have an abnormal posture, it will never just stay static. If you don't accommodate for it or try and correct it, that tendency is going to just be a progression of that abnormal posture. So your goal as a therapist is to help minimize that progression. So if it's fixed or non-reducible, that means you want to accommodate for that to help prevent the progression of that posture. If the abnormal posture is flexible or reducible, that's when you want to try and correct that posture. You want to try and get them in as neutral of a position as possible that they can actually tolerate throughout the day.
Okay, so after we perform the supine mat evaluation and we decide whether that abnormality is reducible or non-reducible, we probably are asking ourselves, how do I correct or accommodate for what I'm seeing? And one of the main reasons that it is so important to, take the time, get the client out of the chair, on the mat table, to figure out if it's reducible or non-reducible is because we don't want to cause any harm to our patients. And if we try to correct a non-reducible posture, we could actually, number one, increase their pain. And, with our nonverbal or cognitively impaired clients, that may manifest, as I said before, in increased agitation or maybe screaming out, okay? Number two, we will create peak pressures right on those bony prominences, increasing the risk of a pressure injury or prevent the healing of an existing pressure injury. And I am pretty positive that our wound care nurses will not be very happy with us about that. Number 3, it's going to promote the progression of that abnormal posture. If you're trying to force them into something their body can't tolerate, they're just going to continue to slide even further into whatever the abnormal posture is. And then lastly, number 4, by allowing them to slide further into an abnormal posture, especially with the posterior pelvic tilt, which is probably the most commonly seen, we drastically increase the risk of falls from the wheelchair and injury from the wheelchair level. Okay? So as I mentioned before, I know I am guilty as charged. We as therapists have the tendency to want to try to fix everything, right? However, if it's a non-reducible postural abnormality, we have to not say, oh, there's nothing that I can do. Can't say that either, but we have to switch gears from I have to fix it to I have to immerse it and envelop it with the focus to decrease peak pressures, which might injure the soft tissue and the skin under that bony prominence. And we also have to try to decrease pain. I have to change gears to start thinking I need to capture the client's now, quote unquote, normal anatomical curvature, because now the kyphosis is our norm. And my goal now is to prevent, again, the further progression of that specific abnormality. And I have to switch gears into thinking I need to support and stabilize the body to obtain and maintain the best postural alignment possible. And this is really going to let us, allow for maximum function and safety in their wheelchair. So now let's take a look at each of the abnormalities and decide what to do when you're dealing with both a reducible and a non-reducible one. So when presented with a pelvic obliquity, whether it's reducible or not, your goal is to try to make even pressure distribution. And you can see that in this illustration down here. So the problem with an obliquity is that the lower IT is really digging into the support surface of the cushion, while the other side is kind of just hanging out in limbo, barely making contact. And this creates peak pressures along, this lower IT. And that's where you're going to start to see a wound develop, really placing that skin and soft tissue at high risk for injury. So the goal is to ensure that the pressure enters evenly along the entire gluteal surface throughout the ITs, evenly on both sides. And how we achieve this is really going to depend on whether the obliquity is reducible or non-reducible. So when dealing with a reducible, again, that means that I can fix or correct this pelvic obliquity, then my goal is to try to even out the pelvis again. And I'm going to actually raise up the lower side by adding to the cushion so that, I can create that even pressure distribution. So I'm going to build up the lower side to create even pressure distribution and have that pelvis neutral. If it's non-reducible, meaning that it's not going anywhere, it is what it is now, but I still need to try to create even pressure distribution and stop it from getting worse. So what I want to do now is I want to fill in this gap. If I fill in this gap and start supporting this higher IT, then I'm going to prevent it from getting worse. And by building up the cushion, then what I'm doing is now both sides are evenly having pressure enter the ITs. They're not even, they're not both in midline now, but pressure is entering evenly throughout both the ITs. So again, your goal is to fill in the gap, prevent it from getting worse because now it's supported, and you want pressure to evenly enter both sides to decrease the risk of a pressure injury. With a posterior pelvic tilt, whether it's reducible or non-reducible, you really need to ensure that you're using the correct cushion and wheelchair depth by taking the right measurements. And that correct measurement is upper leg length on a measurement form, okay? So if we allow a client to sit in a seat depth that is too long or too deep, like this client right here, then the cushion or the seat sling is really going to dig into the back of their knee, causing discomfort and numbness and probably circulation issues. And as a result, either consciously or unconsciously, the client will start to slide forward to really alleviate that area and the pressure to stop that numbness and pain. As well, another big issue is that, a lot of times we're placing our residents on hammocking seat slings, and the cushion starts to bend or become deformed, and it's not doing what it's meant to do, and so the pelvis will collapse into a posterior pelvic tilt. So definitely, the use of a rigid, hard insert underneath of the cushion between the hammocking seat sling and the cushion will help to really create a more stable surface to prevent that pelvis from collapsing into a posterior pelvic tilt. If the posterior pelvic tilt is reducible, the key word that I want you to think of is contours. because you want to try to get the posterior pelvic tilt to as neutral as possible and then stabilize it in that posture. So consider a cushion with both a medial, which is this middle piece contour, and a lateral tapered contour, that it's going to create leg troughs, and that's what you're seeing in gray. This is going to be a predetermined leg trough where the lower extremities and the pelvis can sit to create optimal alignment and pelvic stability. You also want to attempt to bring the pelvis in the client's most neutral alignment with the use of those tapered adductors in combination with a deep pelvic well. So what that does, it creates a shelf for your gluteal surface to sit on, your greater trochanter, and it's going to lock the head of the femur into its acetabulum to really then stabilize the pelvis. And then lastly, you want to consider a cushion with an anti-thrust component. And this is going to reduce the forward migration of those ITs into a posterior pelvic tilt. If, however, that posterior pelvic tilt is non-reducible, then don't worry about correcting it. We have to accommodate for it to protect the skin under the bony prominences and to make sure it doesn't get any worse. So consider more of an immersion and envelopment style cushion that's going to exactly take the shape of the client to really promote maximum pressure distribution, minimize those peak pressures pushing up against the skin and soft tissue, and especially at the ITs, the sacrum and the coccyx from breakdown. You might also want to consider a combination style cushion where it's an immersion envelopment that sinks it in and takes that person's shape, plus offloads pressure, and really has some pre-contoured shape of the medial and the lateral contour to then promote lower extremity alignment and pelvic stability so it doesn't get any worse. And absolutely, guys, when you are dealing with a posterior pelvic tilt, stop using chairs stuck at 90 degrees, and we have to think about opening seat to back angle so that the pelvis can get all the way back in the chair. If we allow them to sit in those chairs that we have in our storage closets that we cannot open seat to back angle, they will never be able to get their hips all the way back, and they will continue to slide into a further posterior pelvic tilt. Okay, now moving on to the next abnormal posture, which is the anterior pelvic tilt. And when dealing with an anterior pelvic tilt, again, whether it's reducible or non-reducible, you need to 100% make sure that you're thinking about the cushion plus the back support. Because the tendency of a person with an anterior pelvic tilt is you see what's happening, and what they're going to do is they're going to try to stack the spine to bring the spine back, the trunk back to neutral to be able to function. And so what you want to do is you want to utilize a cushion and the back support that maximize contact with both the seat and the back and the trunk so that you can create optimal pelvic and spinal stability, plus create even pressure distribution and stability throughout the entire spine. So if you're not using a back support that can mimic their shape, then it's only going to make contact at one point. How are you going to stabilize someone teetering off of one point? How am I going to stop a wound from developing here if this is the only point of contact? Whereas if I use a back support that takes the shape, it's going to stabilize the entire spine, and it's going to have even pressure distribution so that they don't get a wound. And since stability is the goal, providing a back support that is tall enough for the client is key. So you need to take the proper measurement of from the top of the mat table to the top of the shoulder. If that anterior pelvic tilt is reducible and we want to correct the pelvis and the trunk, trying to bring it back to as neutral midline as possible, then definitely consider a cushion that will bring the pelvis back to the most neutral possible and locking it in. So again, the use of that deep pelvic well with the adductors that will lock the head of the femur into the acetabulum, stabilizing the pelvis in the posture that you're striving for. Also, you want to use a back support, like I said, that can contour to the person's spine. So here we can see there's lots of gaps. If we use a back support that can contour to their spine, there are no more gaps. And we can actually bring the person into the most neutral, upright posture that they can tolerate. If it's non-reducible, consider again the use of an immersion envelopment style cushion that will mimic their shape, get that, even pressure distribution, and also, really support whatever it is that their posture is to not allow it to get worse. Or, again, maybe consider a combination style so that they're being mimicked and they're just being supported, but you're also being able to promote lower extremity alignment and pelvic stability through the medial and lateral contours again. And again, definitely look for that back support that's moldable, that can conform to their spine, okay? And this time, we're not going to be able to bring them back to more neutral midline like this gray line, but we are going to accommodate and mimic their curvature in what they're stuck in. And the goal is so it doesn't get any worse. You want to maintain what they have to prevent the progression, but still allow for maximum stability and still allow for even pressure distribution. Moving on to the pelvic rotation, whether it's reducible or non-reducible, definitely think about an anti-thrust component in your cushions. Again, this is going to prevent, one of the ITs from migrating forward and try to keep them both back in alignment. So when the rotation is reducible, you want to use those tapered adductors and that medial abductor again to form those leg troughs for that lower extremity and pelvic alignment. And then those tapered adductors, because they're higher than the pelvic well, again, are going to lock the head of the femur into the acetabulum, keeping that pelvis in neutral, not allowing it to rotate. And then again, the use of the back support that contours through the spine, filling in the gaps and promoting a more neutral spine will in turn promote a more neutral pelvis. If it's non-reducible, definitely think of an immersion envelopment style cushion with a very mild contour. So that immersion envelopment property will allow you to protect their bony prominences, plus support the pelvis, preventing any further progression into a rotation. All right, the windswept deformity, when you're talking about a windswept deformity, one thing I want you to understand is it's not so much talking about what's going on in the pelvis, it's really talking about what's going on at the lower extremities. The underlying cause of windswept deformity is usually the pelvic rotation or a pelvic obliquity or a combination of the two. So your goals would be just whatever your goals were with trying to accommodate or correct for a rotation or an obliquity. But the key is to look for a cushion that can be adjusted, which meaning it can be built up. So you add something to the cushion or you minimize it, taking something away from the cushion to really correct or accommodate for the internal rotation of the one hip with adduction and the external rotation of the other hip and the abduction. Okay, so as well, for sure, when you're dealing with a windswept deformity, avoid the use of elevating leg rest because they're going to decrease femoral contact with the seat surface. And without the femurs really being supported, gravity obviously is going to take effect, and your lower extremities are going to be more prone to fall into this type of windswept posture where it's like a big gush of wind has come in and kind of taken the legs off to the side. So now we're going to go back to Mrs. C. And what did my MAT evaluation at both seated and supine tell me about her postural deformity? And so after performing both her seated and supine MAT evaluations, I really got in there and tried to see what I could move and not move and how much movement she could tolerate. I found out that her posterior pelvic tilt, I found out that her thoracic kyphosis, I found out that her forward neck flexion rotation and her lateral flexion were all reducible. But keep in mind, it wasn't reducible back to quote unquote normal posture, but it was back to her optimal posture. So after I interviewed her, after I made her problem list from observing her in her wheelchair system that she came to me in, and after I performed those MAT evaluations, these are the interventions that I came up with for her. And the first thing that I did was I used a pre-contoured cushion with, and you can see that right here in this picture, that medial abductor and the lateral tapered adductors that I kind of showed you in some slides before, so that I could bring her pelvis back to neutral and then lock her head of the femur into her acetabulum so that I could maintain that as neutral posture as she could possibly tolerate. The next thing that I did is I changed out her back support from that tall straight back that couldn't be molded at all to one that could contour to her spine and that was the proper height. It wasn't 6 inches above the top of her shoulder. It was exactly to the top of her shoulder so that I could create maximum stability and so that I could promote upright posture and prevent her chest and her abdomen from collapsing. I also used an angle adjustable head support that could be moved laterally, and I moved it anteriorly, and then I was able to, it has these little wings on it that I was then able to kind of bring in, so it made good contact with her head to support it, so that when she did fatigue, she didn't go into that posture. So I was able to allow her to keep her head up against gravity as long as she could possibly do it, and then when she fatigued, her posture didn't go into what we saw in the before picture. I also, because I used a back support that had a hard shell, I was able to use a mounted lateral, not a foam lateral, because foam laterals really just don't give you the option of making a precise spot that needs counter pressure to really add trunk alignment and stability. So I was able to use one and put the counter pressure in exactly where she needed it. I also ordered a model of wheelchair that had an adjustable seat to back angle. So I opened her seat to back angle, took it from 90 degrees and opened it to 110 degrees to match the range of motion limitation that she presented with that she actually could tolerate for hours on end. Okay, she could get to 90, but she couldn't tolerate 90. So I sat her up at 110. And this way I really did minimize the risk of her sliding forward. And also this chair had the capability to create a fixed tilt to assist in head control. So when she did fatigue, we would use gravity to try to bring her eye gaze and her head back to midline so that she could continue to interact with her husband and her environment, and she could get that good voice projection as well. The other thing that was really great about this model of wheelchair is that it had armrest height adjustability. So it didn't just jack her arm up and she had to really abduct and kind of have a shoulder height to get her arm on the armrest. It allowed her to be at a comfortable spot even after the addition of the arm trough that you guys are seeing. So it relieved the pain that she was experiencing, and it didn't push her over into a lateral lean to the other side because it was at the correct height. And I definitely changed out her elevating leg rest to standard leg rests that would allow full contact with the seat surface and allow her lower extremities to fit in the leg troughs that were created by her cushion's contours. And then lastly, I added an upper extremity support that was angle adjustable so that I actually could get rid of the edema in her left hand. And so I want to bring one thing to everyone's attention with this client. As you're seeing this picture, you can still see that she has a slight lateral flexion of her neck and that her trunk is slightly still leaning to one side. So I didn't create perfect, but I did supply her with her optimal, allowing her to meet her goals and function as an active member of society again. And that just kind of wraps up for our course that, please understand, optimal does not mean perfect. Function and comfort can have many, many different looks, and we do the best we can for our clients within the parameter of their anatomical issues. But when we accomplish a client's optimal, like I was able to do with her, that allows them to safely function in their wheelchair system, then I say, awesome job. Job well done, guys. And you have achieved what I like to call perfectly imperfect. So that wraps up the course, and I'm going to hand it back over to Robin and Kelly.
So the first question that we got so far is, if someone's pelvis is manually movable, however, when we have completed wheelchair positioning multiple times in devices, he cannot maintain and his pelvis goes back to elevation. Would this mean he is fixed?
No. So most likely what is going on with that one, so if you're able to actually, unless I heard wrong, but I think you said you were able to manually place the pelvis back into a more neutral, so you could move the pelvis in and out of neutral. What's probably happening is, if you think back to a couple of slides where I was talking about posterior pelvic tilt, and the fact that if you don't play with the angle configuration of the wheelchair, they'll never be able to maintain that. So if that person, like my patient, for example, that I kept using throughout this case study, she could get to neutral, but she fatigued so quickly she couldn't maintain that neutral all the time. So I had to kind of find her sweet spot. And I had to then not only get the right cushion and the right back support, but I had to change the seat to back angle of the chair to match what her body could do. So could she tolerate 90? Sure. But she couldn't tolerate for hours. So if I sat her in a 90-degree chair, she was going to slide right back into her posterior pelvic tilt. So what I needed to do was open her seat to back angle to 110 degrees, which is where her pelvis was comfortable for hours and hours, and she wouldn't slide into a posterior pelvic tilt. So what I'm probably thinking is it's not so much the cushion that you have them on, it's the fact that you don't have the right angle configuration of where the seat and the back support are meeting each other. And you can get that through taking a wheelchair model that actually has seat to back angle configuration through the back canes, or replacing the sling back with a back support that through its hardware you can open and close seat to back angle. So that I would probably say is the issue, not so much that it's fixed or flexible, because it sounds to me like it's reducible, not non-reducible. It's more the configuration of your wheelchair.
All right. Next question is, you mentioned all the solutions with both correcting and accommodating for postural abnormality that need for both back support plus a cushion. Is it always necessary to purchase the back support?
So in my very long trial and error that I had when I first started with seating positioning, I always just looked at somebody, I'd have a referral come across my desk, and I just think right away, and I think a lot of people do this, and don't feel ashamed if you do this, because I did it for sure. The first thing goes to what cushion are they on and what cushion should I replace it with? But we're therapists, right? And we know that you're never going to be able to change the pelvis without changing the spine, and you're never going to be able to change the spine without thinking of the pelvis. They interact so much. And if you don't have a back support that can also accommodate or correct for what you're seeing at the trunk, you're never going to be able to correct or accommodate the pelvis. And a sling back that comes on a chair is not able to do that for you ever. And I was actually asked a really good question one time, and someone said to me, why do manufacturers even put a sling back on a chair if they don't do anything for you? And I made this analogy, and I said, you can go to a shoe store and you can buy a $180 pair of running sneakers, or you can go to Shoe Barn and buy the same Brooks, the same brand of Brooks running sneakers and get a $50 brand. One of them is top notch for a marathon runner. One of them is made for someone who might just be using them casually. But what they have in common is that very thin, flimsy foam insert to the tennis shoe. The manufacturer is not pricing them because of that insert. They're pricing them because what foam is it made? What is the toe box shape? What is the contour of this? Is it meant to have gel to help the runner and right? So that's the difference between those two shoes. That thin, slim foam insert is the same. If you have an issue like plantar fasciitis, or you have Achilles tendon or a bunion, then you need to replace that foam insert with something that actually can accommodate or correct whatever podiatry issue you're having. And that's the same thing with the back support. They have to send the wheelchair out with something. They can't just give it to you without anything. So that's kind of like that thin, flimsy foam insert. You have something like a kyphosis, or you have a severe scoliosis or rotation, you need to take that off and then put something on that can accommodate or correct for what issue you're actually presenting with. So yes, I do truly believe that if you want to actually make a seating system and you want to correct the pelvis, we have to consider the trunk and vice versa. And a cushion should never walk out the door without a back support.
All right. Thank you so much for all the great questions, and thank you to Ana for your time. We did have a couple more questions, but because of our time running out here, I will reach out to you via email and connect you with Ana to get those answers. And now for anyone interested in learning about a deeper look into the products that Ana talked about that Direct Supply offers, please help me welcome our fantastic product manager, Kelly Sullivan.
Thank you so much for sticking around for a few extra minutes with me. We're going to today focus on 4 products. These are going to be relatable to what the case study was at the end of the presentation that Ana covered, with a more complex resident with various different postural issues. So we're going to talk about a couple different pieces that you can consider looking at or even purchasing through Direct Supply in the next handful of minutes. All right, so the first product we're going to look at is called the Comfort Shield. This is a very unique cushion in the sense that it answers to a lot. It's going to give you pressure management, advanced pressure management. It's going to offer postural control, and it has some unique features that help with friction and shear. So let's start with that. On the front or the top cover here, if you can see, it's probably maybe a little difficult to see, but in the pelvic region here, there is a piece of fabric, and this is called glide wear. And glide wear helps to mitigate friction and shear. And think about those micro movements. If you're seated in a chair and you're reaching for something, you're going to shift and move a little bit in that pelvic region. And what does that cause? It causes some shear and friction to occur. So this is going to help to mitigate that by using two pieces of fabric that slide against each other to help with that movement and help allow for that movement to take place without the stickiness or high coefficient of friction that you might get towards the front of the cushion, which helps prevent you from sliding out, right? So it's a really wonderful piece of fabric that helps to mitigate that concern. You can see the product is contoured, so the Comfort Shield has more of a saddle design, and that's going to help with abduction control and adduction control as well. Inside, as I open it up, you'll notice, there's another layer here. So we have another cover, and this is great because this is going to help with incontinence. It's their incontinence liner. So really what we're trying to do is make sure that the integrity of the foam stays intact. Having a double cover is going to help with that. Let's open it up even further though and discover what's inside that cover here. So inside we're looking at the actual foam. And right away, you'll probably notice there's a coccyx cutout that's going to offload pressure from the coccyx region. But furthermore, it has a lot of contouring. So it's going to have a carved out pelvic region to offload pressure from the IT bones. It has built up foam in the front. So if you have someone that's dealing with posterior pelvic tilt, it's going to help mitigate that push forward. And again, here we get a real nice view of the built up foam on the sides as well as the foam in the middle, that moderate pummel that helps with leg alignment and better posture. So this is a wonderful product, 3 layers of foam. So that top layer gives you just a little bit of memory foam that helps with that comfort, but more importantly, it helps with immersion. So it's really going to cup the body of that resident and allow for full contact. Great product, especially if you're looking for an advanced solution to go underneath your resident that answers to both pressure management and positioning. The next product I'm going to talk to, this one I've never shown before, and I'm excited to show you. This is called, and I don't have it attached to a backrest right now, but I thought it'd be better to show you how it kind of can move by holding it upward. This is called the Body Link Head Support. It's an adjustable posterior head support. So what I mean by that, is that it can move. It can move with the resident. I can adjust it from side to side, from front to back. So really I can allow for me to cup the back of the resident's head, all the while tilting it to help support them either way, allowing for a better vision plane so they can see the world around them a little bit easier, but more importantly, giving them more support. I can take these wings and I can mold it and cup it around the resident, so I can cup to the cheek if I'm using it to help with a head alignment. And then the back, you can see there's all these links back here. So this is going to give me a lot of flexibility in terms of how I adjust the back of it. I do want to touch the fact too, though, is that with some improvements on the hardware over the years, they've allowed for you to have a secure placement without the resident getting in there and adjusting the back themselves, which happens on some head supports that I'm sure some of you have experienced. Yet it does give the ability for the therapist to simply go in and adjust the back. So if I want, maybe it's hair day, and I want this to drop down, and I want to have full access to their head as they go and they get their hair washed or their hair cut, I can do that without having to remove the entire apparatus from the back of the chair. So it's a wonderful piece. One last story that Ana shared with me that I thought was kind of interesting. They had done a test where they had secured this to a powered wheelchair that weighs a good 600 pounds, and they lifted the entire powered chair up from the headrest, and it didn't break off. There was no bending of the material, or the metal, I should say. So it's a very highly durable product with tons of adjustments. And you also have some options for the pad itself. So if you want different size padding, you have adjustments there as well. The next product we're going to talk about is a back and this is going to be the Actibac. This is going to be a product that is going to be used for more complex residents that might have more severe abnormal posture, that really you need a deep bend that's going to support their back and alleviate pressure points from their back. So think of that resident that you're working with right now that perhaps, if I can do this in balance for you, you can see that back push through and allow for an opening to really cover that entire back without having any pressure points. From there, once I have them seated and pushed back into it, it has a, they call it a bowl reel system. So I simply snap it in, I reel it in, and then it's locked. So it's completely capturing the mold of the back, and it is completely custom fit for that individual. The other nice thing about this is I can also order this with some laterals with a hard shell. So think about your stroke patient that needs some lateral support, but you're not going to do anything with just a foam lateral. You need something with a solid support system around them, wrapping around them. Again, complex resident, have that person in mind. That's what this is going to be really useful for, is really that strong support alongside of them. Because as you know, one of the side effects of a stroke is lack of support in the trunk area, losing that movement or having more looseness in the trunk. So being able to support that person is a nice added feature of the Actibac. And the last product, now this one is a new and improved incredible Incredibac. So a phenomenal little back. This is a great product. It's affordable, but it's more importantly, it's highly adjustable. It's not going to be for maybe your really complex resident that needs the lateral support. So if you need laterals or you need a head support, this isn't going to be your product. But think of all the other residents in the building today that you're working with that maybe they don't necessarily need those two supports. What they need is some moldability. They're dealing with some spinal curvature or spinal rotation. So this is going to help with that and helping to adjust and mold to that back. And one way you can do it is through just as easy as just opening up the back through the zipper at top. If those of you who have ordered the Incredibac in the past probably remember, I remember the stays, the aluminum stays, but you probably also remember having to remove the back completely from the wheelchair to get those stays out. Now there's a zipper right on top here, so while that person's still seated, you can get to those aluminum stays quite easily. The other improvement is that they have several slots for you to choose from. So instead of just having two that go right along the middle of the back, I can pull these stays out. Let me get to them real quick here, or at least one of them. I can bend it, mold it to that person, and then I can slot it in to several different options I have here for where I want that positioning to take place. So you have more flexibility, more choice in terms of how you're going to work with that resident. And for you, it's going to be a time saver because you don't have to keep taking that back off when you need to readjust or change the stays. The foam too is very soft. It's going to allow for more comfort for the resident, and it's a real easy piece. It just goes right onto the back. There's really no tools. You remove the back, the vinyl back, and you just secure it right on, nice and easy without any tools. So it's a great product, and I think it's going to work really nicely for a good majority of your residents that, again, are not in that complex definition, but are working towards trying to just give them more comfort and remove pressure points from their back because of any kind of rotation that they're dealing with. So Incredibac, it's new and improved. It's a great product. You're going to be able to find that through Direct Supply as well as the other three pieces that you saw here today. Looking forward to hearing from you if you have any questions. I'm more than happy to address those questions. But we hope to see you again at the next webinar that we host. Take care.
All right, thank you so much, Kelly, and thank you again to Ana for your presentation today. If you have any questions, as Kelly said, please feel free to reach out. You can email us at webinars@directsupply.com. Thank you again for attending today.